All right. Welcome everyone to the 2021 VNC Water and Health Conference. I am Angelur Islam and I work for the Water Institute. Thank you so much for joining the session today with me. I will be the host for the session today. Before we get started, let's go through some housekeeping announcement. We will have a networking event on Remo that will gonna happen 3:30 to 5 p.m. Eastern Standard Time, and that is happening daily. So please feel free to join, network with colleagues. It's very helpful. We always have a late early show, and for day 3, it will gonna happen 10 p.m. today Eastern Standard Time. Today's late early show will gonna be about Southeast Asia and Pacific region, and Dr. Regina Sauter and Alexander will gonna discuss the lessons learned and how to apply them into those regions. Today, we are very pleased to announce that we will gonna have a career in WASH for young professionals, and that will gonna happen after the poster session today at 3:30 to 5 p.m. Please feel free to join those sessions. It will gonna be very helpful for the young professionals. Now, couple of instructions for the session today. This session is going to be recorded. Everyone but the verbal presenters will gonna be muted. And if you have any questions for our presenters, please feel free to use our conference platform Pathable and use the chat tab to type in any questions. Our presenters already uploaded the slides and relevant materials under the Files tab. I will gonna be monitoring the chat, so I will address any questions to the presenters after the presentation is done. Every presenters will going to have around 10 minutes, and then it will gonna be followed by 5 minutes Q&A session. We really want to thank our sponsors, Biorad, EG Water for Everyone, IWHA, and the UNC Water Institute. Thank you so much for our sponsors. Without their help, it will not gonna be possible. Now, without wasting any time, I want to introduce our first presenter for the session. It will going to be Megan Miller, who is graduate student alumni at UNC Gillings School of Public Health. Megan, whenever you are ready, please feel free to share your screen and begin your presentation. You will get around 10 minutes. Thank you.
Hi everyone. Again, my name is Megan, and today I'm going to go over a methods comparison for the surveillance of SARS-CoV-2 in North Carolina community wastewaters. So as we all know, we've been living in a pandemic for quite a while now caused by the SARS-CoV-2 virus. And a key to stopping the spread of the virus, both earlier on in the pandemic and even now as cases spread and vaccine rates are consistently lower than we need them to be, is robust testing and surveillance networks. Due to testing-related barriers such as supply and cost, finding alternative ways of surveillance is key. Now, SARS-CoV-2 is primarily spread through aerosol and respiratory droplet, but individuals do shed virus in their stool. And so the concentration of that virus in wastewater may actually more accurately capture the true infection rate of a community than we could get if we just went around testing everyone. The use of wastewater as an indicator for community infection prevalence is a concept known as wastewater surveillance or wastewater-based epidemiology, WBE. And so the idea is that infected vigils in a community would shed virus in their stool that then gets concentrated into the local wastewater treatment plant, where scientists can then take samples, quantify the amount of virus in that sample, and then use that to inform epidemiological models to capture the infection rate in that community. These approaches have been proven to be very effective in monitoring the presence of a pathogen in wastewater to control outbreaks. We saw that with polio, and also it's been used for other human enteroviruses such as the norovirus. What polio and the norovirus have in common is that they are non-enveloped human enteroviruses. So what we see to the left of this figure, these persist for long periods of time in wastewater systems, so it makes them easier to find. Alternatively, SARS-CoV, MERS, and SARS-CoV-2 are all enveloped viruses, which break down much more quickly in the wastewater matrix due to their lipid envelope. However, recent studies have shown that they do actually persist longer than previously thought, and there have been several researchers who have been successful in detecting SARS-CoV-2 since the start of the pandemic in wastewaters. Now, all of these studies are starting to contribute to the development of SARS-CoV-2 specific surveillance methods, particularly related to two areas. So first, how do we concentrate the RNA in the wastewater sample? And then how do we detect the specific RNA that we're looking for, in this case SARS-CoV-2, out of all of the RNA that we concentrated? And this was the goal of the North Carolina Policy Collaboratory Wastewater Pathogen Tracking Research Network, was to develop and optimize methods for the surveillance of SARS-CoV-2 in wastewaters, particularly in North Carolina. And so to contribute to this aim, Dr. Jill Stort's lab at Gillings, who was my advisor, contributed to this collaboratory, and also to the entire Stort lab did as well. So shout out to all of y'all, and I'll recognize you specifically at the end of this presentation. But specifically, my research focused on determining the optimal method for quantification. And so my research had three objectives, and today I'm going to focus on two of them. First, comparing the sensitivity of the two methods I looked at, which were two different types of PCR, so RT-qPCR and RT-Ddpcr, for the detection of SARS-CoV-2, and then evaluating whether qPCR can offer sufficient detection reliability for use as a standardized surveillance method for SARS-CoV-2. So this study looked at two different wastewater treatment plants, Owassa here in the Chapel Hill Carborough area, and Pittsboro, which is just down the road in Chatham County. Both of these wastewater treatment plants have differing size and profiles, and so they offered a good look at either ends of the spectrum as far as wastewater treatment plants go. Samples were 24-hour batch composite samples, and they were sampled after the headworks in the wastewater treatment plant. They were collected weekly by our lab over a 24-week period from July 10th to December 15th in 2020. So I know everyone knows probably what PCR is and is very familiar with it, but just a quick general overview for people who aren't familiar. It's a way that we use to identify specific nucleic acid sequences that are present in a sample. So you combine primers and probes specific to your target sequence with your sample, and then a cocktail of enzymes and reagents, and then you run this reaction through a series of specific thermal cycling conditions to facilitate the 3 steps of PCR. What these steps do is they replicate your target nucleic acid sequences to detectable levels. So the first type of PCR I looked at was quantitative PCR, and this bases target concentrations off of a standard curve, which is created by the user, and that relates CT values, which is the cycle number at which your target reaches a detectable fluorescence by the PCR machine. It relates that cycle number with the target concentration in your sample. And this is the most common and accessible type of PCR. The new type of PCR that I then looked at as well is called Droplet Digital Pcr. And instead of basing target concentration off of a standard curve, it does absolute target quantification by taking the sample and breaking it up into tens of thousands of individual droplets. These droplets then all undergo a PCR cycle, with each droplet acting as its own individual PCR reaction, and then you put them in a droplet reader, which reads each individual droplet for the presence or absence of your target sequence. It then uses a statistical method in order to output your target concentration in your sample. So normally in PCR, you set a limit of detection, or LOD, and a limit of quantification, or LOU. Samples that come up under your LOD you count as non-detect because they're not trustable, and samples that come up below the LOQ you count as positive, but you don't assign them a concentration due to the related uncertainty. I decided to develop my own system of classifying positive and negative samples, as the process used in this study, the processing of the samples, we had a very limited recovery efficiency. So the processing control that we spiked into our samples before processing them, at the end, we only saw recoveries ranging 2 to 8% of what we originally spiked. So this means that potentially, one, our processing control probably wasn't the best, but two, we were only recovering a tiny percentage of what we put in, meaning that when we recovered a tiny bit of SARS-CoV-2, that was likely indicative of a large concentration of SARS-CoV-2 present in the original sample. So I wanted to be able to use those lower concentrations in my analysis because they indicated still significant amounts of SARS-CoV-2 in our original samples, while still accounting for their associated uncertainty. I don't have time to go into the classification process that I used at the moment, but I'm glad to go into more detail during the Q&A if we have time. I also used two statistical tests in my analyses, one to measure method detection consistency between the two different targets that we looked at, the N1 and N2 targets for SARS-CoV-2, and one to measure the difference between the two methods, qPCR and Ddpcr. So for the qPCR data for the Owasso wastewater treatment plant, N1 was found to have fewer non-detect samples and more reportable concentrations than N2, and statistical tests showed that considering concentrations below the LOD and LOQ increased the consistency between the two targets. For the Pittsboro wastewater treatment plant, the detection rate for both targets was comparable. Again, detection consistency for qPCR method increased significantly when concentrations below the LOD and LOQ were considered in the dataset. And also notice that Pittsboro just had a lot more non-detects for the SARS-CoV-2 virus than Owasso did. Here is a temporal trend of the detected SARS-CoV-2 concentrations for both targets across both wastewater treatment plants in our 24-week sampling period. All targets in wastewater treatment plants captured this large spike from July 21st to August 11th, followed by several dates of no detects. And Owasso samples also showed a spike kind of at the end in December, but Pittsboro did not follow this trend. Here we have a summary of the Ddpcr data. Overall, you can see that each target has a much higher rate of reportable concentrations. Also notice that Pittsboro has a much, again, larger rate of non-detects than Owasso, which is the same trend we saw in the Q data. Targets were tested for correlation across the N1, N2 target for each wastewater treatment plant. Both showed high levels of significant correlation between targets. And so this indicates an improved level of consistency for the Ddpcr method over the qPCR method. Here we have, again, temporal trends of the SARS-CoV-2 concentrations detected using the Ddpcr method. The data captures the same spike that we saw in the Q data, but it also captures an additional spike directly after the spike that the Q method did not pick up. And so this indicates that Ddpcr is potentially more sensitive to maybe smaller spikes or trends in SARS-CoV-2 concentrations. So comparing the two methods, Ddpcr resulted in a higher detection of positive samples than Q across all targets in wastewater treatment plants. And comparing the sensitivity of the two methods, qPCR detected reportable concentrations in only about 15% of sampling dates compared with DD's 81%. And this increased sensitivity for DD is probably related to a couple factors. First, with DD, we removed that what we call the PCR bias that comes with the external calibration of that standard curve. And we also have increased statistical power and sensitivity because instead of just one reaction happening, we're getting tens of thousands of replicates via the droplet partitioning. So we can say for certain that DD has superior sensitivity to Q in the context in which this study was taken. We also have some comparisons for cost. So the startup cost for Q is less than DD and also is more accessible generally across labs. DD has the potential to actually be less expensive than Q when you look at cost per reaction if you can increase the processing efficiency, just because it has the potential to process a larger volume of samples. But it doesn't take away from the fact that qPCR is just more accessible to labs across the state. So surveillance of RNA viruses in large volume environmental water samples require high levels of sensitivity. So the question becomes, if qPCR is more accessible to labs, are these rigid LOD and LOQ thresholds too restrictive for wastewater surveillance of SARS-CoV-2? Considering the limited recovery efficiency, I would like to make the argument that even values below this LOD and LOQ still indicate significant levels of the target virus and should be considered in the data set. We still need to mitigate uncertainty, and so different methods of classification, such as the ones that I used in this study, could be used to help mitigate that uncertainty and assign uncertainty to values while still being able to consider them in the data set. And so it comes to the specific use application of each method, which could be for Q, we may use it to see detect the presence or absence of the virus in a sample, whereas for DD, we can use it to maybe quantify those actual target concentrations to be used in models. So these are some of my conclusions, and just thank you so much to the Stewart Lab, Knox, Alyssa, Con, and Akil, David, and thank you so much, Jill, for your guidance and support.
Well, thank you so much, Megan. It seems like it's mostly lab-based. I'm not a lab person, but I can come up with a question, I think, as people is feeling, oh, we got a question from Colleen, Professor Colleen Norton. Is it more difficult to monitor at the smaller treatment plant?
In this specific study, we did find it a bit more difficult to monitor at the Pittsburgh treatment plant. We did see potential, we just couldn't control as much where the sampling was happening because we would just go pick up the sample instead of doing it ourselves, and we hadn't worked with them as much in the past. We did see evidence of potential addition of coagulation or coagulant before when we didn't. So they might have been adding a coagulant when we wanted to sample before that was happening. So we just had a lot less control and uncertainty associated with those samples.
Thank you so much. We got another question from Leah, and question is, are your results already published so we can read more about it?
They're actually going to be incorporated in a manuscript that my lab is working on, and so TBD on that. But no, they're not already published.
Okay. Okay, another question from Professor Colleen as well. What recommendation do you have for monitoring at smaller treatment plants?
What recommendations?
Yep.
Well, it just depends on what access to resources that smaller treatment plants have. If you have a qPCR machine, they still provide great, as I was showing, presence absence of the virus. When we were sampling in the midst of the height of the pandemic, it was obvious that virus was definitely there and was going to continue to be there, but as we kind of move into, it seems more of a season of spikes and lulls, if you have access to qPCR, it could be a really great method even for a smaller plant. I would say you could also link up with a university as well, and they could maybe partner with you to help you do some monitoring or surveillance.
Okay, we have time for one more question, and I will take the one from Andre. Are you using higher cutoff number for extraction efficiency or whole process control for Ddpcr compared to qPCR?
So the processing control that I referenced was a whole process control. We didn't actually have a specific extraction efficiency for extraction itself because we wanted to capture how much virus we were losing over the entire process. So yeah, our processing control, I will say, was bcov, which was not the best processing control. And if we were to do this again, we would probably pick a different one. But it still makes the point that you see a very small, and other studies saw this too, you see very limited recovery through processing, which indicates just higher concentrations of SARS-CoV-2 in your original samples.
Got it. Thank you. Just a quick question from me. What kind of statistical method you use for the analysis?
So I used Spearman's rank correlation to compare across the targets, and then to compare between the two methods, which I didn't get to present today just due to time. I used the McNemar's chi-squared.
Okay, cool. Thank you so much. Thank you so much, Megan, for the presentation today. Now we'll move on to our next presenter. Our next presenter will be Professor Colleen Norton. She is the assistant professor at University of California, Merced. Professor Norton, whenever you are ready, please feel free to share your screen and begin your presentation.
Yeah, thank you. And thank you for the introduction. I'll share screen. Oops. Hope everyone's doing well. Good morning, good afternoon, or good evening, depending where you are. It's still morning here in California. So timer. So thank you, everyone. This is my 6th time being at UNC Water and Health, though I miss being in person. It's great to have this online, more accessible version to meet everyone, and I'm learning a ton so far in the conference, so I really appreciate it. Today I get to present to you about effort. I also have the privilege to be a part of Wastewater Sphere. So that's a Wastewater SARS Public Health Environmental Response. It's a global data center for wastewater monitoring of SARS-CoV-2. So Megan provided a great introduction or example of wastewater monitoring in North Carolina, if you were there earlier in her presentation. So this is a huge collaborative effort from led by Dr. Joan Rose at Michigan State University, Gerchen Medema and KWR Water Research Institute, Panis at Ventec Technologies is our software engineer and data consultant. Vajra Allen, I think she's here today, is from PATH, which is a nonprofit that works to accelerate health equity, so all people and communities thrive. Andrei is a postdoc at Michigan State. He's here today, and Kristen Kadansky is a graduate student, just started here at UC Merced. In the chat. So if I missed anyone that's joined later, I apologize, but this is a huge effort that I have the privilege to present about. So today I'll just go a brief background. I did put some polls in the chat. It looks like most people are aware of wastewater sampling. Take time to answer that. I'd like to get to know all of you. I don't get to see you in person or your faces as much, but see who's joined and where you're coming from. It looks mostly from North America and Europe. But some may not have responded to the poll. So we'll go over the project overview, data flow, collected data, a brief demonstration through PowerPoint. I don't trust myself to go directly to the website, but there's links in the files to the data center. So I encourage you to go to that website even during this talk to start looking around in ways that you can all contribute if you aren't already in acknowledgements and questions. So this is the same image that Megan showed about wastewater-based epidemiology, or it's called wastewater surveillance, environmental surveillance, wastewater monitoring, whichever term you prefer or are more familiar with. So it's another way to monitor the spread of the pandemic through wastewater. There has not been infectious virus found in the wastewater. It has been found in feces and stool, but the primary spread of SARS-CoV-2 is respiratory aerosols. So this is what's monitored in the wastewater is viral fragments or RNA. But anywhere from 40 to 80% of people shed the virus in their stool. So it can even be an early warning system as people are asymptomatic or they're not. There's a lag in clinical testing or getting tested and reporting those values. So there can be a lead time of anywhere, they've said it's around 5 or 6 days, but anywhere from a couple of days to 2 weeks, depending on how robust your clinical testing is. So this is the data center. It's part of the Global Water Pathogens Project. I've presented about GWPP before at UNC. So that was a huge collaborative effort to update the FEACHM Sanitation and Disease book. There's also the knowledge to practice tools, that there's a mapping tool and a treatment plant sketcher tool as well in the website. So if you go to the main page, you can click on COVID-19, and now the data center is active. So you can visit there. You can go directly to sphere.waterpathogens.org. So the mission is to advance environmental surveillance of sewage to inform local and global efforts for monitoring and supporting public health measures to combat disease. So I started with a team between UC Merced and UC Davis, COVID Poops 19 dashboard that wastewater surveillance really grew. I mean, it was used prior for a few decades prior with polio and other viruses to monitor in the wastewater, but it really started accelerating. So I saw the Johns Hopkins University dashboard for COVID-19 cases, and it's like, well, we really want one for wastewater, and it could be this early warning system. We're getting closer, but more we're trying to create this repository of data and a place to like put everything in like one format and visualize it. And so we integrate data generated from field deployments in a lot of low and middle income countries. Right now we have Malawi and Pakistan, also doing monitoring in Ghana, Bangladesh, and some Nepal and other countries that their data will be shown soon. We also take what COVID Poops has gotten from the dashboards. There's like 93 now that have downloadable data, and we have been working with the postdocs and students, and everyone's working a lot to put it in the one data form. There's a lot of different methods. Even Megan showcased between Ddpcr, qPCR, and you have your limit of detection and all these variables, and whether you're monitoring in the solids or the liquids. So trying to put it in one format to display together. Yeah, so develop approaches for data visualization and like scientific advancement. So there's, you know, all this, we've had all this data so that you can download it and potentially perform like a meta-analysis or learn from it. And we're also providing use case studies, which I'll hit on at the end of the presentation about the public health use case of wastewater surveillance. If you're looking to use this tool, it's still not used everywhere. So we're providing some public use cases and examples. So this is the data flow, as I said, from the COVID Poops 19 dashboard. We then kind of harvest these dashboards and websites of what are downloadable, which is like, about 20 or so. We also get direct submissions from the data from PATH, that's coordinating working group and monitoring in those other countries. Since most of this monitoring has happened in like 60% in high income countries, but there is some data wastewater sampling happening in low income countries. We meet with different partners and we get submissions, especially from Europe is really active in this space. And then, as I said, the postdocs, grad students, and us are like curating this data management, putting it in a data form that you can download from the website into a CSV file. And then we use Esri, ArcGIS, online for the mapping and the dashboard and story maps for the use cases. And we have a website that we embed the map in and the data to visualize the study sites. And so our database currently, we have 24 countries, over 20,000 samples. The 97 data points I'll show you are between like the different dashboards and that we have available now, and then 668 sampling sites, 12 data sets, and more are coming by the end of 2022. We're working on some already to add. So I'll take you more to the website, sphere.waterpathogens.org. So you'll see when you go there, there's the global map. You can click on See Global Map or the top global map and get to the map to see these different points here. And so the grayed out versions are future dashboards we hope to incorporate that we know of from, COVID Poops, and the green circle around them are the data dashboards that we have, like all the data in our data template, like the flow, the limit of detection, presence, absence, the SARS-CoV-2 genome copies per liter. And then we have data dashboards that aren't standardized quite yet. We might not have the limit of detection or all the variables, but that we're hoping to collect. And so you can click on any of these points. It's active. You can zoom in, like on the left-hand side, there's a zoom function. And so if we click on United Kingdom or Scotland, it's one of a great example. You can either go directly to the website, to their dashboard, or you can go through our visualization for view sites. If you want the most like up-to-date data, we recommend you going to the website. We try to update monthly, so it's more like of a repository or standardization. But so go to the website if you want to see like the up-to-date results. And so if you view sites, then you can see Scotland here, and then the dots of presence and absence color-coded, and they're bigger, the larger the flow, or the more people, population served. And you can play with the data a little bit in the timeline and see over time how the presence and absence has changed. And then you can go to Trends View in the upper right corner. And also you can see, if you click on any of the points, you can see like kind of their population served, maximum detected concentrations, average concentration, and how many samples. But if you go to Trends View, then you'll get the dots, the size dots go away, but you can see if it's increasing signal. So this is based on CDC methods of linear regression. I think they usually use the last 3 samples. We're using the last 5 samples. If the signal is increasing or decreasing over time, or a slight increase or no change. And you can also still use the toggle on the bottom for the timeline to see how it's changing over time. And you can click on any individual point and you can see the concentrations, if you see on the right, for a certain site over time. And so now if you go to data, if you want to go outside of the map, you can hit back or the left-hand corner to get to the home page. So here's where all the data are listed and you can download. You can also contribute data, and then if you go there, you can ask to contribute and you can download our data form as well. And you can search the data sets by scale and by region and by country. And you can view, like if we take EWOG here, you can view the data and the files and download them, and like also get how many sites collected samples and what target they're using N1 and 2E. And then the last is going to use cases. So that's on the top right. Sorry about that. So if you go to the top right, go to use cases. We have 2 up right now, the Netherlands and Catalonia, and these are through story maps. So Soterios, I think I saw you here and I forgot to maybe mention that you were here. He and Gerchen, Dr. Medema really worked on these to get public health use cases. So not just like research, even though that's very important for methods development, but also how it's being used to inform public health. So you can click on the Dutch one or Catalan one, and we're adding more, and you can also contribute or ask to contribute a use case if you have one. So these are just some screenshots of the use cases. The Dutch sewage case is using wastewater to identify areas for increased clinical testing. And the Catalan one was monitoring to inform some public health methods. They monitored like 56 wastewater treatment plants, and they spread them evenly throughout the region to help manage the pandemic and identify outbreaks. So hopefully you've enjoyed this presentation. If you are monitoring for wastewater, know people, we'd love to have them contribute. You can follow us on Twitter at Water Pathogens or at COVID Poops 19. And again, this is a huge collaboration between all these different entities and people, and want to thank them for their efforts. But you can always, you can contact us through the website. You can also contact me through my email, and I look forward to any questions. So thank you so much.
Wow, thank you so much. We definitely need a placeholder for the wastewater treatment, and great initiative, Professor Norton. I think people are trying to fill up the question. I have a quick question. So if someone from any country is interested to share their data, how they can do that? And also the next question is, how do you identify or differentiate between the trustworthy or valid data? Does that make sense?
Differentiate between which?
Not differentiate. How do you identify the valid data? That if someone is sharing the data, then the question came like if that is a valid or not, right? Or is it trustworthy or not?
Oh, okay. The like quality control.
Yeah.
Yeah, so first for contributing, there's multiple areas, but under the data section, you can contribute your data, or we have like a contact form. And you can also contact me or Dr. Rose or Dr. Medema as well if you're interested in contributing. And for QA/QC, I mean, we do have like in the data form, like the methods and the reference to the protocol, like we reference their publications. For the submissions we're getting from the sites that the field deployments like Malawi, Pakistan, and Nepal and others, we do check if we see that the values maybe like are a little high, but sometimes they're monitoring in non-sewered areas, so that might be high. So we do check the data sometimes, or we look for sort of inconsistencies. Just sometimes it's like copy paste issue in a data form. So we do have like a QA/QC process for like the data as far as like the students enter into the form, and then the PIs will check before it gets uploaded to the website. And so we'll Panais, who manages the website. So we try to install those controls throughout.
Got it. And then if anyone wants to use the data from your website, can they do that with proper acknowledgement or citation?
Yeah, they can use the data. Of course, we recommend that they acknowledge, wherever you get the data from. If you're citing in a publication, we actually have like a ID number for the data set that you can cite in a publication. As far as like wastewater sphere, like it's nice to acknowledge, but it's more if you're using the certain data sets, acknowledging the data providers. We also, when we get data from submissions from people, we do have data agreements that have been vetted by the Michigan State lawyers and such, and we do like have those agreements in place that makes them more comfortable like submitting the data.
Got it. Well, thank you so much. Please use the polls provided by Professor Colleen Norton, and also ask any questions into the Pathable if you have. Seems like we don't have any questions coming in. Thank you so much,
This
Professor.
is the identifier, just in case you to
Okay.
cite the number. So thanks.
Okay, got it. Thank you so much. That's very helpful. Thank you so much, Professor Norton. Now it's time to move on to our next presenter. Our final speaker for the COVID session will gonna be Professor Gabriel String. She is the research assistant professor at Tufts University. So, Professor String, whenever you are ready, please share your screen. Oh, okay. Begin your presentation. Thank you.
Perfect. Excellent. All right. Well, welcome everyone. I'm excited to be presenting to you today on some research that we conducted last year, doing a systematic review looking at contamination, stability, and disinfection of surfaces with SARS-CoV-2. I want to highlight up front that this was a collaborative effort, mostly led by Noah, Elizabeth, Elsa, and Miguel, who were undergraduates working in our research group, and assisted by Christine and supported by Danielle Lantain. So with that, let's get into what we found for the systematic review. And I will also note up front that this was data that was made available either in preprint or published by July 10th of 2020. And I know this is now October of 2021. So just bear with me while we talk through this and where there has been maybe some new data contributions since we conducted this work. So as we all know, WASH is really critical in outbreak response. Not only is WASH key to dignity, but it's also really important for preventing disease transmission. We're all, I assume, quite familiar at this point in time with how critical hygiene messaging and hygiene was, particularly early on in the COVID pandemic, particularly looking at hand washing, but there were also surface disinfection protocols that were put forth by World Health Organization and the US Centers for Disease Control. And most of the early surface disinfection protocols recommended to clean suspected contaminated surfaces with soap and water, and then to use an approved disinfectant such as sodium hypochlorite or bleach, or something else that was already approved by the EPA on surfaces as a disinfection mechanism. So what we wanted to do was try to fill in the gaps in understanding how surfaces were critical or important in the transmission of SARS-CoV-2 and how we could disinfect those surfaces. So for the systematic review, we put together a PCOS framework, which is on the right-hand side. I won't step through all of that. It's available online to read about in more detail the framework we use, but I do want to highlight that we did pre-identify wash interventions, which we thought could potentially interrupt transmission of SARS-CoV-2. And that was looking for studies on hand washing, surface disinfection, mask disinfection, water treatment, and wastewater treatment. To do this work, we downloaded data from two different databases. The first was the NIH's COVID-19 portfolio, and the second was CDC's COVID-19 research articles downloadable database. It was really challenging for us to do an assessment of bias. Again, this was pretty early on in the pandemic. So what we did was we assessed whether or not, we categorized whether or not papers were published and peer reviewed or whether they were preprint. For our analysis, we extracted and tabulated the data, grouped it by theme. We tried to convert units for comparability across data types, and where possible or where it was needed, we requested raw data from authors. So from our first download of the two databases, we had over 68,000 articles to screen. We then completed a second search, which added another 27,000 articles from both of those databases for screening. So this was up through July 10th of 2020. We then went through and did a first round of exclusions for screening the articles into the systematic review, and that involved screening the titles and abstracts, looking for anything that indicated that it was not going to be related to wash interventions to interrupt SARS-CoV-2 transmission, or if the abstract or title indicated that it was going to lack primary data. After title and abstract screening, we had 365 articles for full text review. At this stage of those full text articles, articles were excluded if they were not related to any of the pre-identified interventions, if they had no primary data, or if they did not clearly report on their outcomes. We then reference chained an additional 33 articles into our systematic review from those articles that had passed this level of our exclusion. And in total, we ended up with 142 articles after full text review. Those could generally be divided into three primary categories for data extraction. The first was 10 articles related to wastewater treatment. The second category was 78 articles related to surfaces, surface disinfection, and then lastly, 58 articles related to mask reuse. So for today, we're only going to talk about those articles that were related from the systematic or from this, screening process related to surfaces. But I will note that we do have a preprint article on all of the mask reuse data available, which I'll link at the end. So before we get into some of the details, I just wanted to walk through this evidence summary. So generally, when we think about hygiene interventions with the or hygiene to interrupt SARS-CoV-2 transmission pathways, we can divide it down the way we're thinking about it between fomite transmission and then other practices. So for fomite transmission, we found really three areas that had a lot of studies and one that was missing. So the first area was contamination of surfaces. There were 35 studies related to this. So that is saying where SARS-CoV-2 contamination is being found. The second was looking at surface stability, or how stable SARS-CoV-2 was on a surface once it was found there. There were 16 studies for that. As of July 10th of 2020, there was missing information related to the transfer of SARS-CoV-2 from surfaces to fingers or to other objects. And then there were 27 studies related to surface disinfection. At that point in time, there was really missing data or limited data around water, wastewater treatment, and hand washing. And I'll note, as we've sat through this session today, that clearly there has been progress made since July of 2020, particularly around data related to wastewater. So thinking first about what surfaces are we finding SARS-CoV-2 on. So there were 35 studies that presented this information. And if we look through the settings being primarily healthcare settings, household settings, non-household accommodations, and then other sort of shared spaces, a bulk of the testing was being conducted in healthcare settings. They were sampled more than any other setting. And then as a result, the highest portion of those positive surfaces were seen in healthcare settings. Most of the positive surfaces in healthcare settings were coming from the patient rooms. There were also a high portion of positive non-household accommodation samples and laboratories, and a lot of the laboratory surface contamination likely represents secondary contamination from labs that were doing early testing with SARS-CoV-2 samples early on in the pandemic. I will also note that none of these studies tested for viral infectivity or viability. So this was all studies that were looking at presence or absence of SARS-CoV-2 RNA on these surfaces. Digging into this a little bit more, from the 25 studies that were conducted in healthcare settings, patient rooms had the highest number of positive samples reported. And if we look at where those surfaces were, you can see that that's primarily coming from utensils and soft bedding. And then if we look at the 5 studies that were in non-household accommodations, the surfaces that had the highest positives were, again, utensils, also patient PPE, and then high-touch electronic surfaces. So next we want to think about, well, now we know some surfaces that we're finding SARS-CoV-2 RNA on, but how long does it persist on those surfaces? That's really important if we're thinking about possible transmission from surfaces for SARS-CoV-2. So there were 16 studies that looked at stability on the surface. There were 9 organisms that were used in testing in these studies. So you can see there's a mix of coronaviruses and some bacteriophages. And there were actually 7 studies that had been published at that point in time or had data available that had completed testing on stability specifically with SARS-CoV-2. And then there were 29 unique surfaces that were tested. Predominantly, these are non-porous healthcare surfaces, such as stainless steels and plastics. But there were also some porous surfaces that were involved in some of the data, and that included things such as cotton and paper surfaces. And I will note that unlike the surface contamination studies, these studies did test for viral or surrogate infectivity and viability. So looking at the 7 studies related to SARS-CoV-2 specifically, and how long it persists on the 3 surfaces that were tested, which were steel, plastic, and nitrile gloves, you can see that there's a range of humidities and temperatures and resulting half-lives for all of these studies. Really, the key takeaway here is that as the temperature and humidity were increased in these studies, the half-life of SARS-CoV-2 on the surfaces decreased. And then lastly, we were interested to understand how we disinfect these surfaces. So if we know where SARS-CoV-2 is and we know how long it could persist on that surface, how do we disinfect those surfaces then? There are 27 studies that related to surface disinfection. There was a systematic review published very early in the pandemic from Kampf et al., which summarized sort of all of the pre-SARS-CoV-2 research on coronaviruses and potential surrogates. Of those studies, you can see they were fairly evenly split between suspension tests and surface testing of the disinfectants. And there were 27 disinfectants that were summarized in this systematic review. Of the articles that were, of the data that was generated and the articles that were published or preprint after Kampf on SARS-CoV-2 specifically, predominantly those disinfectants were tested in suspension, and there were 20 different disinfectants that were tested. So if we look at the 9 studies, that did suspension tests on SARS-CoV-2 specifically. We can see that we have a range of disinfectants that have been tested, looking at acetic acids, heats, different ethanols and hand sanitizer, soaps, and UV systems. What's interesting to note is that you have different ranges of concentrations and contact times that are tested with all of these disinfectants. In general, we see that heat at 60 degrees Celsius for less than 15 minutes or at a lower temperature, around 37 to 42 Celsius for a longer time, had a 6-log reduction of SARS-CoV-2 in suspension, as did a hand rub contact time for 5 minutes, had an almost 6-log reduction. What's really critical to highlight here is that in suspension, the reduction of SARS-CoV-2 is going to be very dependent on the specific dosage and contact time of the disinfectant. But again, we've been talking about surfaces, and so there were only 3 studies that had presented data related to surfaces as of July 2020, and that was utilizing disinfectants, including simulated sunlight, and then deep UV LED irradiation and UVC irradiation. And those surfaces were stainless steel, Petri dishes, and chamber slides. You'll note that simulated sunlight and the UVC irradiation at the specified concentrations and contact times were able to achieve a over 4-log reduction. But mostly the results on surface disinfection with SARS-CoV-2 was still fairly limited. So some key takeaways from this research was that there was an inability to align SARS-CoV-2 contaminated surfaces, so where we were finding surface contamination, with the data on survivability or stability of SARS-CoV-2 on that surface, and then aligning that with the effective disinfection data. So that makes it hard to understand how to interrupt transmission along a particular chain. There's a knowledge gap, particularly at that point in time, on fomite contribution to SARS-CoV-2 transmission in the pandemic in general. We now know that it is not a primary pathway of transmission. What we noticed from looking at all of this data, particularly the data that was being published early on in the pandemic, was that there's really a need for standardizing test methods. It became very hard to compare data, which makes it really hard to make recommendations and guidance documents from quickly. And then there is a need for further research around hygiene interventions, particularly hand washing to interrupt SARS-CoV-2 transmission, looking at surfaces and disinfectants that are relevant to non-healthcare facility contexts. So for instance, on that last slide, the 3 studies that I highlighted were utilizing healthcare facility surfaces such as the plastic, glass, and stainless steel, and utilizing equipment that's available in a well-resourced healthcare facility, but may not be available in other settings. And then lastly, there needs to be a verification of the EPA's N list, which is their list of approved disinfectants with SARS-CoV-2. So with that, again, I want to thank the co-authors on the study and our funding from the Tisch College of Civic Life and NSF grant. On this slide, I've highlighted, and I'll put it into the chat on Pathable as well, the links to the manuscript here, herein on the SARS-CoV-2 data related to surface contamination, stability, and disinfection, and then also the mask disinfection and reuse data. And I'll note that we have been following up this work by updating our systematic review, but as a result of kind of moving into another phase of the pandemic, we're finding, particularly for some of the surface work, that the amount of studies that are coming out are much less than there was early on, likely again as more information became clear about how SARS-CoV-2 was being primarily transmitted. But with that, I'm happy to take any questions, and thank you very much for your time.
Thank you so much, Professor String. Please feel free to use the Pathable platform to type in any question for Gabriel String. I have a quick question. When you are considering the outdoor contamination, did you look at the wind speed?
Yeah, so that was of the studies that looked at the outdoor contamination. I don't believe that wind was something that was listed. I know that they tried to report on temperature and humidity, and primarily those studies were sampling on surfaces that were outside of healthcare facilities or outside of hospitals. Some of the high touch surfaces that were sampled at that point in time included like crosswalk buttons and benches and dirt actually outside of healthcare facilities.
Got it. Thank you.
Mm-hmm.
Okay, I think people are still typing in. So it seems like temperature and humidity, when temperature and humidity will gonna increase, then the half-life of SARS-CoV-2 will gonna decrease.
Mm-hmm.
Then what will happen if temperature will gonna increase, but humidity is decreasing or something?
Yeah. I mean, that's a really good question. What happens in those contexts? What I will say is that after this systematic review was published, we've been working on a grant with USAID Bureau of Humanitarian Assistance to complete studies looking at chlorine disinfection on low resource surfaces, so surfaces that may be more common to low resource settings, such as tarp and cloth and nitrile gloves and such. And what we had built into looking at that study was what happens as you change temperature and humidity, because that is, again, a primary concern, I think, for many field responders that we were working with in humanitarian contexts where the humidity and temperature conditions are very different than the conditions that were being monitored in the labs where some of these early studies are being conducted.
All right, thank you. We have, is it a question or comment? It came from Barbara Evans. Also appreciate your comment now, of course. Comment, okay. We know that fomite are not dominant transmission pathway, was reflecting that one of the drivers of the initial confusion about this were driven in part because this research on fomites was better established and more in the mainstream than any relevant research on airborne transmission. So for all of us, it's important not to always remember and communicate the absence of evidence is not evidence of absence. And indeed, it's difficult to publish now or very small results. I am so appreciating the thoughtfulness, these challenges of everyone in this session. That's a good comment.
It is. Okay. Yeah, I was going to say that it was very interesting looking at data that was being generated. Again, this was from kind of the first 6 months of the pandemic, what was available. And at that point in time, again, some of the data not being very comparable across because everybody's trying to generate data as quickly as possible early on. Hopefully now, as a result of this pandemic, we do have a lot more data that will be available for whatever next is in the pipeline, if it's data that's useful in any way towards future coronaviruses.
Yeah, thank you so much. We don't have enough time, so we have to wrap up. But thank you so much, all the presenters, Megan Miller, Professor Colleen Norton, and Professor Gabriel Strain. Thank you so much for your presentation today. And thank you so much, all the audience, for your patience. And stay tuned. We have a poster session at 2:45 Eastern Standard Time today. And we will also have a networking session at 3:30 p.m. And without any delay, I just want to briefly thank our sponsors, Easy Water for Everyone, Biorad, and IWHA. Thank you so much all. Thank you. Bye-bye.